Good afternoon and welcome to HIT Policy Update with Dr. John Halamka, CIO at Beth Israel Deaconess Medical Center, a webinar tweet chat combo from HealthSystemCIO.com sponsored by OnBase by Hyland. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com and I will be your moderator today. We will have a simultaneous tweet chat, which is hosted by our Managing Editor and Director of Social Media, Kate Gamble. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat on the right-hand side of your screen in the Media Viewer panel. We'll also be using the Q&A panel. You can send questions in at any time in the Q&A panel. Leave the default set to all panelists and send those in. We'll take them later in the program, but you can send them in as they occur to you. And at the beginning of the program, we're going to throw out 2 poll questions. Your polling panel will open automatically, answer the questions, and then we'll look at the results later in the event. And you could download the deck using the URL on your screen. It's at the bottom of some slides, and it will be sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to hear from Dr. John Halamka. Then we're going to hear from our sponsor, represented by Lorna Green, Manager of Global Healthcare with OnBase by Hyland. And then we'll have our Q&A. So it's time for our poll. I'm going to open these 2 polling questions now, and if you can answer them, we will look at them, as I said, later in the program. First question. Is your organization preparing a contingency plan for NIH and HHS budget reductions, yes or no? And is your organization preparing a plan for ACA repeal and replace, yes or no? So you have definitely some time to answer those, but you might as well get it out of the way now, and we'll look at them later in the program. And with that, we are ready to hear from our featured speaker and good friend, Dr. John Halamka. Dr. Halamka, thank you for joining us.
Well, happy to be here. And, of course, what a fascinating time for us to have this discussion, given that today is the day where the Affordable Care Act revisions will be voted on. We've seen the presentation of a new proposed budget for our next fiscal year with substantial budget cuts to such things as education, the environment, and health care. We've seen the appointment of what appears to be a new national coordinator. I'll talk about that. And yet a lot of unknowns. And so, as is always the case, Anthony, when we get together quarterly, I do my best to interpret the evolving activities around us, and not totally knowing exactly where the future will go. So let's open it up with where things are as I think. Here we are on Thursday, the 23rd of March, where they're going. Since I sent these slides to Anthony a few days ago, I hadn't included the appointment of John Fleming. So who is John Fleming, what is the position, and what does it all mean? So 2 days ago, John Fleming, a representative from Louisiana, he's a family doc with a history of providing services in the military and the private sector for substance abuse, treatment, mental health. And so a person who is very much a practicing clinician, understands the nature of the practice environment, was named, we think, to this position of Deputy Assistant Secretary of Health for Health Technology. And of course, one of the things that's a bit challenging about that title of Deputy Assistant Secretary, does that imply there's an Assistant Secretary for Health Technology? I don't know exactly how the hierarchy goes between Tom Price and John Fleming. Who reports to whom, how many layers there are in the middle. If there is a deputy assistant, is there an assistant? If there's an assistant, is there a full secretary for health technology? And all of these are a bit unclear. If you read the interviews with John Fleming, he is even unclear as to whether or not this new position, which is in effect a secretarial position overseeing healthcare information technology, is the head of ONC or not. And so, of course, it begs the question, if you have been just named to a new position in a secretarial hierarchy and ONC isn't in your title, will there be an ONC? So one looks at the blueprint budget that was issued by the Trump administration. That blueprint budget doesn't have a lot of detail. So although it says such things as 18% reduction in HHS funding and NIH funding cuts, et cetera, there's nothing that says ONC will be funded or not funded. So what have I done? I've, of course, called all of my contacts in Washington, and I have asked folks at ONC, folks who are in leadership positions in government today, will you be reporting to John Fleming? Will John Fleming be reporting to you? Will you have a budget? Will you not have a budget? And the answer is all the civil servants on the inside don't know. So I think what we could just say, again, it's Thursday, is John Fleming has been appointed to this important position. There may or may not be additional appointments coming, and it's a little unclear what the role of ONC will be. Either John will lead ONC or John will not lead ONC, and the funding will or will not be made part of the FY18 budget. Now, part of ONC, again, Anthony, not a slide because this is all so new, is that the 21st Century Cures Bill stipulated that the HIT Policy Committee and the HIT Standards Committee would be eliminated, and they would be replaced by a new committee called the Health Information Technology Advisory Committee, the HITAC. I am starting to hear people in the industry being nominated to that committee. I have been asked to write reference letters, for example, for people who are being nominated. And the GAO put out a call for membership, and there is, I think, until April, mid-April or so, the opportunity for individuals to submit their credentials to the Government Accountability Office, the GAO. So I think what we'll see, it's been a little slower than in previous administrations, but we're finally getting to the point where we've got Tom Price and Seema Verma both confirmed as head of HHS and head of CMS. We're getting down to the next tier of the ONC-like functions, the Federal Advisory Committees supporting the ONC-like functions, and people are being named, vetted, talked to, et cetera. So it seems to be moving forward, but again, not a huge amount of clarity and no significant public announcements quite yet, but watch the next couple of weeks. So now back to the slides that I sent you, Anthony. What we know is that the Affordable Care Act repeal and replace activities have been submitted, but they are very much a moving target. I mean, as we are on this call, the Freedom Caucus is in Washington meeting with Trump, trying to revise the already revised Republican various proposals to repeal and replace. And as I told Anthony, if you look at these next 10 slides, I've given you, and I'm just going to show you the notion of there are changes in coverage and changes in Medicaid and changes in the way that allocation is done between subsidy and tax credit, et cetera. So these are for your reference. What I'm going to do now is actually go through the major themes that you're seeing comparing Obamacare, the ACA, and the Republican bill, at least as it stood yesterday, because today it may undergo some additional revisions before it's voted on. So remember, the idea with Obamacare was that we're going to have this individual mandate and an employer mandate with the idea that lots of healthy people, young people, would sign up for health care. And those folks would pay premiums that would ultimately make the insurance and risk pool large enough to cover all the sick people. So it wasn't that Obamacare was trying to be mean-spirited, forcing everybody to buy insurance against their will. It was purely trying to build a larger risk pool so that we would cover those folks who are increasingly elderly and sicker and they need additional coverage dollars. The House Republican bill repeals the individual mandate and repeals the employer mandate. And so there will no longer be a penalty if you do not have insurance. And so, again, it'll be sort of interesting to watch what happens to premiums when there's fewer people in the risk pool, and maybe it's the young, healthy people who will now bow out, making the situation actually worse, less affordable than it is today. Remember, the idea with Obamacare as well was to provide subsidies for various out-of-pocket expenses. and that would be such things as deductibles and co-payments and that sort of thing. And so these sort of direct subsidy payments would be repealed in 2020, so there wouldn't be cost sharing any longer. There were also premium subsidies in Obamacare, and these were really linked to income, and the idea was to offset the cost of premiums and deductibles, and so you got more of a subsidy as you had less and less income. And the Republican proposal, interestingly enough, doesn't really tie subsidies to income. It gives tax credits that are tied to age. And so, for example, you would get a tax credit of $2,000 for a person under 30, $4,000 for people over 60, and potentially there would be some additional tax credits to deduct certain health care expenses from your taxes directly. But so this would be sort of fascinating because you will now have age-related tax credits that are a bit blind to your income, and you could imagine some inequities of those who are old but wealthy, to a point, getting more tax credit capability. Now, there is a cap on the individuals who qualify for tax credits of $75,000 per individual and $150,000 per household. But as you'll see in my slides, this all gets pretty complicated when you actually get into the details. Medicaid expansion was also a huge feature of the Obamacare activity, and that is the eligibility cutoff for Medicaid was raised to 138% of the poverty level, and 30 states took advantage of this, and Massachusetts got a $52 billion Medicaid waiver and have our own novel programs. So, of course, the interesting question, and this is the change that seems to be baked in the Republican revisions, is that there would be total reduction in the amount of subsidies available for Medicaid expansion, and the bill would propose capping federal funding per enrollee and taking a look at how much the states were spending in 2016, and the idea was that Medicaid expansion is growing faster than inflation, and so we better put a cap on it, and there'll be some states that were spending a lot in 2016 and maybe will do okay, but other states that weren't spending a lot in 2016 and their caps may be relatively low. The other change is there is an amendment to the original proposal by the Republicans that suggests states could mandate a work requirement for some Medicaid beneficiaries and then figure out, are you able-bodied, are you capable of working, and, make your Medicaid eligibility based on looking for work or actively working or that sort of thing. So that was not part of Obamacare. Health savings accounts, we had those with $3,400 per individual and $6,750 per family in a tax-free health savings account under Obamacare, and there may very well be some reductions in that. We're going to see. I've seen a couple of different proposals. One suggests that families and individuals and spouses will be actually incented to do health savings accounts, but then if they didn't spend all that money, they would no longer be able to roll over their the monies they didn't spend. And so this is where it's that one, Anthony, not quite sure, the details on whether that one's going to be attractive or unattractive.
Mm-hmm.
And other than that, you may very well see such things as allowing insurers to charge older Americans more than they charge younger Americans, give states the options to set their ratio. Under Obamacare, the ratio was set as 3-to-1. You could only charge older customers 3 times the prices they charge to younger ones, and in the new proposal could be 5 times as much as younger ones. So again, we'll see where that one goes. And certain things like dependent coverage of your 26-year-olds in the home, that's kept. Pre-existing conditions policy, where you cannot be in any way discriminated against for pre-existing conditions, that'll be kept. And then, of course, the debate that's being had today on whether essential health benefits need to be included in insurance plans like maternal health and wellness care and those sorts of things. and the idea that an insurance company cannot set a lifetime limit on the total expenditure view, that's also persistent. So I think, Anthony, what we can say in summary is the popular parts of Obamacare, dependent coverage, pre-existing conditions, essential health benefits, prohibition on lifetime limits, we save. Certain things are changed, like the charging of older Americans, health savings accounts, Medicaid expansion, premium subsidies, but the direct payment for out-of-pocket expenses, employer mandate and individual mandate are going to be repealed. So there you go. I mean, that's as much as I know about where that bill is at the moment, but does it materially impact healthcare IT is probably a question you're asking yourself. And well, I mean, it doesn't specifically, the ACA doesn't specifically address meaningful use, MACRA, MIPS, the inpatient prospective payment system, all these other activities. The thing that, of course, you just wonder, and it's why the polling questions are as they are, if Medicaid expansion is restricted. For example, the governor of Massachusetts issued a letter yesterday noting it would cause a $1 billion gap in the Massachusetts budget if the Medicaid expansion was reduced as proposed. And so hence, if there's significantly less state funding and funding to hospitals ultimately gets reduced, might you see budgets tightened and healthcare IT spending reductions just because of operating expense challenges? Could be. And that's where, you look at this and you just ask, what will be the financial health of your healthcare organization in a couple of years if these significant changes in reimbursement happen? What will happen to your emergency department if you have people who drop out of coverage and now are using the emergency department for primary care? These are some of the things that, of course, we all have to ask. And so let me go back to the slides now, Anthony, and I'm just going to reflect a bit on the budget. So you've probably seen the budget proposal, which reduces the Health and Human Services funding by 18% and also reduces a number of other federal agencies. So, Commerce down 16% and Education 14%. And what you see is there are really two, and of course EPA 31%, but you see the couple of agencies that benefit. You see the Department of Defense gets a 10% bump, Homeland Security a 7% bump. So I only reflect on that budget because if you start seeing a very significant reduction in HHS funding, you might see some of the regulatory and compliance enforcement departments shrunk. So might there be a little bit less focus on regulatory and compliance activities? Could very well be. Will there be, if there's a 20% cut in NIH, academic medical centers see substantial reductions in grant funding, and therefore that will also cause additional budget strain? So, reflecting on this budget, it certainly looks good for the Veterans Administration and Defense, but it may not actually look so rosy for the health sector. And again, do we see any specific healthcare IT-related detail? Not quite yet. Which is why, as I put in this slide last time, I think we really need to be careful not to panic that everyone I talk to at HHS, CMS, ONC, FDA, CDC, they all say the existent civil servants are executing the regulations and legislations that were put in place by the previous administration. They have every expectation that pay for quality, pay for outcomes, value-based purchasing, care management, population health, all these things will still be important and necessary as we go forward. So as you start thinking about your healthcare IT investments for the next year, recognizing that some parts of the United States have already moved to risk contracts, others are still fee-for-service, but the theme is that the country can no longer afford to pay for quantity, and we need to pay for quality. And so putting in place those IT systems that allow you to aggregate data across the community, look at variations in care and outcomes, be able to discover high-value providers and hospitals and differentially direct traffic to them, do telemedicine and telecare, be able to deliver more services near the home, all in the interests of keeping people healthy and reducing total medical expense. I don't think you can go wrong with that. I mean, you'll have your own regional and local issues and your state government issues and all this federal government change around you, but if you reduce total medical expense, improve outcomes and quality, and put in the care management systems and customer relationship management systems and aggregate databases to do that, healthcare information exchange activities, it's all good. So, lest, Anthony, people get pessimistic or feel overwhelmed, stay the course. Yes, individual policies will change. With the appointment of John Fleming, you might see MACRA and MIPS deferred a bit. You might see meaningful use stage 3 eliminated, but it's still not going to change the need to do value-based purchasing and to move away from our current paradigm of focusing on volume. So I hope that gives you comfort and gives you guidance. And just since, I saw Anthony at HIMSS with 42,000 of our other closest friends, you saw the themes at HIMSS. That is big data analytics and care management and population health, moving beyond the EHR and moving to the next level. So the products and services that are going to provide you what you need to survive in a value-based purchasing world are very much top of mind at HIMSS, as well, of course, a bigger focus on the consumer and patient as consumer, and patients and families with new tools, mobile technologies, even such things as having Amazon Alexa in your home and having it be able to schedule a doctor's appointment or be able to offer you basic triage medical advice. All kinds of interesting things we're seeing at HIMSS, but they're all the same basic theme, which is keep people healthy in their homes and reduce total medical expense, because we would much rather keep you at your local community hospital or your primary care doctor's office than a downtown, expensive, tertiary, quaternary referral facility in an ICU. So that's my advice for the month, and of course I will continue to track all this, and one will hope that we'll see clarity really in the next few days on some of the Affordable Care Act revisions I described, and what the appointment of John Fleming means and the appointment of the HITAC members, and then we'll get back to our usual state of monthly predictability as we have people in place and processes in place and committees and all that other good workflow. So, hey, Anthony, let me turn it back to you so that Margaret can make her comments, and then I'd love to hear some Q&A.
All right, great. Thank you very much. I just want to remind everyone that we do have a poll open. A couple of questions. Look in your polling panel and answer the poll. And also, go ahead and start sending in your questions in the Q&A box, and we will take those. So now we are going to hear from our sponsor, represented by Lorna Green, Manager of Global Healthcare with OnBase by Hyland. Lorna, thank you very much for joining us and sponsoring today.
You're very welcome, and thank you for letting me be here today. I appreciate those remarks, Dr. Halamka, that they were encouraging and helping us to move forward. I just want to talk to you real briefly about OnBase by Hyland. I know many of you have your core EMR, whether it's Epic, Meditech, Allscripts, Cerner. That's your core, and we want to protect that and help you utilize that to its fullest. But we all know that there are other pieces of patient data that come into our record, whether it could be wound photos or EKGs or ultrasound images, consent forms, all different kinds of data that can be used, as Dr. Halamka said, in looking at analytics and looking at our populations. So that's where OnBase comes in. We're an enterprise content management platform, and we are, in the old days, you would have started describing us as the scan, store, retrieve. And that's where it only begins, is with scanning in of documents. We can electronically bring in documents in all different formats and then display them up to your users, your clinicians, your people in finance in a way that can be utilized to benefit your company. We have mobile products. We integrate with all the major EMRs, and our security is natively built in to help you reach all the security and privacy issues that you need. So what I want to mention just briefly to you today is one component of our software, and that's workflow. If you look at this slide, you see all the different ways that data are brought into your record. It could be from scanned documents, email, other office documents, notes, things that are already in your system. If those get brought into a system, somebody's got to do something with them. And OnBase has a workflow product. Utilizing this workflow product, you can decrease the cost of your working staff, help automate some of their processes, free up their time to do things that are of higher value. We also, using workflow, can support your compliance initiatives. And it does help increase revenue and customer service. And when I talk about workflow, it can be used in all different areas of your hospital, from policies and procedures all the way through invoicing to PO, anything that often has either a paper document or a Word document or some sort of working piece of paper or document can go through workflow, can be sent to different people and routed to different areas of the hospital for use. As we talk about workflow, let me see if I can, there we go. The important things to remember about workflow is documents and data drive processes, but workflow does enable organizations to automate and manage your processes more fully. And then, of course, when your users work more efficiently, they prioritize work faster and do a better job at what they're doing. And then also utilizing workflow, you're able to measure and standardize what's being done in your organization. As I said, workflow is just one component of our software. We work in all the different areas of your hospital. That's why we're considered an enterprise content management solution. And as part of the slide deck, my email address and phone number are on there. If you have any questions, thoughts, and want to learn more, we would love to talk to you. Thank you. Back to you, Anthony and Dr. Halamka.
Well, thank you so much, Lorna. We appreciate you sponsoring and encourage everyone to go ahead and check out OnBase by Hyland. So with that, we are going to take a look at our poll results. Let me get those open for you. So you should be able to see them now. So Dr. Halamka, we see that for question number 1, is your organization preparing a contingency plan for NIH and HHS budget reductions? 63% are not preparing a contingency plan. Your thoughts on that result and your advice for those folks?
Well, it's just, I guess what's interesting is an academic medical center, which has substantial amounts of NIH research funding and indirect costs, may be more differentially impacted in the short term by some of these reductions. So I guess, Anthony, that one doesn't surprise me so much because it depends on your funding stream. Are you Medicare, Medicaid, private? Are you research or you're not? So if your organization is not vulnerable to NIH budget cuts and maybe you don't have a substantial Medicaid population, from what we're seeing, Medicare is not going to be affected materially, and certainly private insurance obviously will just continue to percolate along, although, as I said, if fewer folks enroll in private insurance, you might see some premiums escalate, which would impact employers and potentially employees with a cost share, but probably not the hospitals. So that result is reasonable.
Okay, second question. Is your organization preparing a plan for ACA repeal and replace? A much more even split here. 51% are not, 49% are. Your thoughts on that?
Right, and so I think regardless of where you are in the United States and regardless of the size of hospital or healthcare system, you have the potential of seeing increased emergency department volume. You have the potential of seeing fewer insured covered. You have the potential for seeing changes to Medicaid and budget challenges, but those budget challenges may not arise for 2 years or something like that. So I think that's sort of reasonable as well. You've got those who are the early adopters and probably less risk averse who recognize that if the emergency department volume suddenly increases, they're going to have a throughput problem, and those others who are going to be watchful waiting. And given the fluidity of the situation, again, that's a reasonable result.
Okay, very good. Okay, I want to remind everyone, go ahead and send in your questions now in the Q&A box and leave the default set to all panelists. So let me just pose to you the overarching idea that's going through my head as you were talking. Hospitals have made some pretty serious investments in technology, spent a lot of money, probably incurred quite a bit of debt to put some of these systems in. If you're making, it's kind of a rough situation to be in if you're making investments in one economic environment, one environment of carrots and sticks, looking at the incentives, looking at what's there, and then you wake up in another environment after you've spent that money where you don't have the razor-thin margins you had before. You don't even have those. It can be a little bit of a scary time. Your thoughts on that?
So I think you're absolutely right. I mean, no one would argue that we should go back to a paper-based medical record, right? You can't analyze paper. You can't secure paper. You can't share paper across teams of caregivers. I think the question is, as we implemented these electronic systems, many of them included features and functions that we had to do from a regulatory compliance perspective, but didn't necessarily add value to the clinician's day. So as I scan the United States market, what I see is 50% of clinicians want to quit because they are overwhelmed with the amount of data entry and burden. So I guess I don't see hospitals and doctors' offices in any way losing their initial investment, but I would hope the next couple of years allows them to refocus on efficiency, usability, quality of practice life, instead of just compliance and regulatory mandates, and maybe doing a lot for federal government agencies that doesn't so much help the local healthcare providers practice at the top of their license. I guess another trend I wonder is, will you, in the next few years, and this is, Anthony, very speculative, see some new entrant into the marketplace that is offering a very substantially less expensive solution to accomplish what clinicians need done? Now, I don't have any particular company in mind. All I see is that, and I'm not picking on any one vendor, right, but you start looking at hospital bottom lines and you hear, oh, this organization laid off a couple hundred because of the cost of their EHR. Oh, this one had their debt downgraded, and this one lost their CIO or their CEO all because of a budget bust. What it suggests, again, no fault here, because we were given a set of federal mandates that required these investments. But going forward, if the requirements are fewer and there's more flexibility, might that be an opportunity for alternative solutions that cost substantially less? You know, cloud-based, mobile, modular, these things may enter into the marketplace as cost pressures escalate.
Yep, very good. Question from the audience. Do you anticipate MACRA, as currently configured, will be impacted by the new administration over the next year?
So again, this is very speculative, but since 2 days ago when we heard John Fleming was taking this new position, I've been watching all of his comments and all of his interviews, and not clear what his authority is, but his opinion seems to be, it's not that MACRA and MIPS is bad, but it might be deferred a bit, give folks a bit more time to prepare for it. So I guess my feeling, when you look at MACRA and MIPS, what does it require? 4 things. We're going to practice and measure quality. We are going to attempt to control medical expense. We're going to adopt innovative technology, and we're going to attempt to have practice redesign and enhanced workflows. I've never heard anyone say, oh, any of those 4 goals are bad. It's just a question of how prescriptive the goals will be and when the regulatory compliance will be required. So keep watching. I suspect the quality measures, many of them will be simplified, made specialty specific. We'll give you much, much more latitude. The IT requirements will be more, you decide what to automate based on your workflow and specialty needs, and maybe we'll be given an extra year to work on that. So, but it's not going away. I mean, the idea, as I say, fee-for-service has to go, so the MACRA MIPS march to value-based purchasing will stay.
Great. Next question, is there any guidance for Medicaid providers? Will they align with the Medicare QPP? What sources of information are available?
Well, you know, sometimes, Anthony, what I do, rather than to offer any inappropriate advice, I call my friends at CMS. And so, interestingly enough, I emailed a number of people at CMS that exact question 2 days ago, and I actually have a couple of folks at CMS working on it. And so, what my promise to you will be is when I get the read on that from CMS, I will share it with Anthony, and we will get it out, as well as I'll of course include that in my next policy update. But it's as I say, sort of a funny time because you've got, you know, a whole lot of change happening. So I'm deferring to CMS for their guidance and their timelines.
Okay, and we'll get that to the individual that asked it. We'll get that out. Another high-level question. When we talk about surviving in this environment financially, as we make these significant investments, not just in the EHR, but in all these population health-related technologies, in order to get where we want to go and start improving outcomes and keeping people healthy. It's a lot of money that hospitals are spending. You know, we've talked about this before. You know, if they're doing it really well, they're reducing their fee-for-service business line. They need to correspondingly be taking on risk-based contracts in order to see a benefit financially from keeping people healthy. Any more advice you can give on sort of migrating down this road and getting into these contracts so that you're not spending the money doing what you should be doing, but you're not, your bottom, you know, your financial situation is just deteriorating because you haven't moved where you need to go from a contracts point of view?
And Anthony, you have hit the leadership challenge of 2017 squarely on the head, which is, if you move too fast to kill your fee-for-service business, you will die. If you move too slow to adopt value-based purchasing, you will die.
Yeah.
So when do you move? Well, in Massachusetts, it turned out to be pretty easy to decide because today, as we talk, I have $2 billion of value-based purchasing contracts right now. 80% of our volume is value-based purchasing contracts. And what happened in Massachusetts was the local payers actually moved faster than Medicare. So the handwriting was on the wall a couple of years ago that we better invest in care management, customer relationship management, data aggregation, quality analytics, and all that other stuff, because we would otherwise lose our shirts in all these alternative payment model contracts. So we've already moved. But other areas of the United States are definitely in that tweener period. So my advice to the person who answered the question is skate where the puck will be. Put the IT systems in place that are needed for value-based purchasing, so when the CEO walks to the CIO's door and says, oh, do we have that care management and customer relationship management capability? The CIO could say, absolutely, I've been working on that. So glad you asked. Because if you wait, when you're asked the question by the CEO, you will be a year or more behind the 8 ball.
Right.
So start working on it now with the vision that certainly within the next 2 years, you are going to be working in a very different reimbursement environment.
Very good. Well, I think that is where we're going to wrap it today. When you close out your window, take a moment to answer our post-event survey regarding continuing education. For those who hold the CHIME CHCIO certification, attending our webinars gets you 1 CEU, so let CHIME know you were here. And if you've asked us to do so, we will. You can use the final slide in this deck as a certificate of attendance for any other CEU program. We'll put this on YouTube with all our other archives, and you can access it there. You'll get an email when it's ready. If you'd like us to produce a webinar for you, contact Nancy Wilcox. You can go to our website to see our upcoming schedule. So with that, I want to again thank our good friend Dr. Halamka, Lorna Green, and OnBase by Hyland for sponsoring today. Please check them out. And thank you to our attendees. So with that, everybody have a wonderful day. Thank you.
Thank you.